Hello and welcome to the Pediatric Network. My name is Mike Marinas. I am your chiropractor and host here for everything evidence-based when it comes to pediatric practice. So today on the Pediatric Network, we are going to be talking with Dr. Dean Gersun. He's an ear, nose and throat specialist who practices from the Netcare Linksfield Hospital, and he has a special interest in newborn feeding as well as oral restrictions, which is exactly why we have him on the network today, because we're going to be speaking with him about ankyloglossia, or more commonly known as tongue ties. So this is not only a special interest of Dr. Gersun, but also something personally he's dealt with himself having a tongue tie, his sister having a tongue tie, 3 of his 4 children having dealt with tongue ties. So this is an expert in the field from personal experience as well as clinical practice. So without further ado, here is Dr. Dean Gersun. Hello and welcome to the Pediatric Network. My name is Mike Marinas. I'm your chiropractor and host here for everything evidence-based when it comes to pediatric care. And today I am so thrilled to be able to invite Dr. Dean Gersun onto the network. How are you doing, Doc?
How's it, Mark? Thanks so much. Appreciate you having me here. We talk about kids and tongue ties especially, which is my passion.
That's the thing, man. Anything about kids, we're happy to go here. And tongue ties, such a big thing at the moment. A lot of people been talking about them, especially I found in the last couple of years, it's really something that's kind of exploded onto the scene compared to before.
Yeah, so it's very interesting, and we'll speak about this before we go into actually what is a tongue tie and how I kind of got into them. That I think tongue ties have always been around. I don't know if people have just been more observant at the moment and taking more notice of it. But I do think that often tongue ties can be a scapegoat for people having difficult feeding. And I say, oh, it must be a tongue tie, there must be a problem. Or sometimes people are just overdiagnosing. But certainly, I think it's probably the former, that people have, they've always been around and people are actually looking at them more. And now that there's a lot more evidence and a lot more investigations and treatment that is going on, especially in the lactation consultant kind of field, that we are diagnosing more and treating more.
Yeah, I think that's where I started to get really turned on to tongue ties, was looking at the lactation consultants online CPD courses, because then they brought out a whole thing on tongue tie, and I was like, hang on a second, this is a thing. What got you involved in looking at tongue ties, Doc?
Okay, so I had a tongue tie, my sister had a tongue tie, 3 of my 4 kids had tongue ties. And it was something that when my first daughter was born about 7 years ago, my wife was having some feeding difficulties, and we'll go and later we'll chat about the different feeding difficulties that you can have. And we saw that she had this massive tongue tie. I knew I had one, and it was cut when I was 12. The only reason it was cut was because I was having my tonsils taken out, and quite upset that I couldn't blow chewing gum bubbles because my tongue was anchored down. So the ENT said they had cut it at the same time. So that's why I had mine done. And I didn't ever think about it, that it could actually cause feeding problems, until we had a child of our own. And so when I started doing some research into it, and I saw it was not being taught at all at an undergraduate or sometimes at a postgraduate level. Something was kind of being overlooked and managed very poorly, this in the government and the private sector. And that's when I started looking into it. And actually the lactation consultants were the people who opened my eyes to what a tongue tie is, how it works, and how it should be managed. I almost just became their technician in the beginning, cutting them when they wanted them being cut, and just watching the progress of my children, of my daughter not having hers cut, my next 2 children, my boys having tongue ties, and what a difference it made to my wife and their feeding. My second child was cut on the second day. My third child, I was waiting with the scissors when he came out. I asked the obstetrician, asked him here, grabbed the scissors, and before his first latch, he'd already had his tongue tie cut. Wow. So within the first 30 seconds of life. So it's from personal experience and just watching how badly it was taught, or seeing that it wasn't taught at all. I kind of stepped in and made it my field.
And I suppose also that's going to give you a certain empathy with the moms and dads that you see coming in now, where the mom is talking about there is a feeding issue. You've been through this. You've lived this.
Sure, it's very easy to give advice, I found, when you're not a parent. And so number one, being a parent, and number two, being a parent who's experienced that problem, it's a lot easier to empathize. And if it truly is a tongue tie, an anterior posterior, and we'll get into that later, it really can be life-changing for the baby and for the mother. And it's an instant relief that once it is released or cut, the mom really notices an instant difference and the baby's feeding completely changes.
Unbelievable. And it's something that can be that effective so quick and can change a trajectory. I mean, it can keep a breastfed baby breastfed. It can
exactly
do so many things. So let's talk about a tongue tie. What are we talking about?
Okay, so we're first going to talk about the classic tongue tie, which is the anterior tongue tie, which is the one that people probably have seen and heard of. So there's something underneath the tongue called frenulum or frenum. Sometimes overseas they call it a frenum. And it's a membrane that goes from the anterior part of the tongue along the floor of mouth in the midline, all the way down to the base of the tongue. And all people will have some sort of tongue tie or frenulum underneath their tongue. The tongue tie becomes problematic when this frenulum is actually anchoring the tongue in the mouth. So we go through different grades, which we can speak about later, but this membrane can go all the way from the tip of the tongue. So the tongue looks heart-shaped. It can't even extend out past the back teeth, past the inferior, the lower teeth. And it's unable to get underneath the nipple and form airtight suction against the areola. So the tongue needs to get underneath the nipple into the groove between the areola and the nipple and form an airtight suction to pull that nipple in and out of the mouth. If the tongue is being anchored or pulled back by this membrane or tongue tie, then you're not going to make an airtight seal. The problem when you don't have an airtight seal is every suck, the baby's going to slip. And that slip is like sandpaper on the mother's nipples, so excruciating pain. They can get blisters and bleeding, and to compensate for that, often they will bite. So it's extremely unpleasant for the moms. They have slip and bite and slip and bite, and that's one of the main common presentations. Very painful nipples, bleeding, cracked, sore nipples, and a very, very shallow latch. So that's the classic anterior tongue tie. The posterior tongue tie is something that's very controversial because some doctors, and rightfully so, will say that everybody has a posterior tongue tie. So posterior tongue tie can be just that the frenulum is very far back, or it can be a high-riding genioglossus muscle. So this is the muscle that joins the tongue to the inside of the mandible. And if this is a high-riding muscle, it actually can keep the tongue kind of pushed back towards the posterior of the mouth. So even though on general inspection and examination, you'll have a look inside the baby's mouth and you won't see this classic membrane and heart-shaped tongue, the child still might have a tongue tie. And that's the situation often. Child is born, mom is struggling to feed, pediatrician or healthcare worker, nurse, whoever examines the baby said, no, there's no tongue tie, I can clearly see. Then send them to a lactation consultant a few days after struggling at home. They say, no, it has to be a tongue tie. And that's when they usually end up at me. Thank God most hospitals have been employing lactation consultants to come past to help the mothers, because they're the ones who taught me as well all about it. Yeah. And they'll generally say to moms, no, this child has a tongue tie. And often it's, who do we believe? The parents say the pediatrician, and the nurse maybe say they don't have a tongue tie. The lactation consultant says they do have a tongue tie. And they often don't know who to believe. There's so much to say about this. Obviously, I don't want to bash any other profession, but it was something that was very, very badly taught as well to my pediatrics colleagues, older and younger. And unless they've kind of gone into it themselves and spoken to lactation consultants, they either don't know how to look for it or don't believe in it. So just to clarify, the anterior tongue tie is a membrane. It looks like a membrane. It goes from the tip of the tongue backwards posteriorly, and the posterior tongue tie is either a membrane that's very far back or high-riding genioglossus muscle that's right at the back of the tongue. And the mechanism that both of them cause feeding or poor latch or feeding problems is that the tongue fails to get underneath that nipple and get into that groove between the areola and the nipple.
Okay. And so both of them are going to have an effect on baby's ability to be able to feed.
Sure. If there's a poor suction, he's not going to draw out proper milk. Can't have a shallow latch and just kind of bite on the nipple. He needs to get real suction, pull the nipple in and out, and to be able to draw the milk into his mouth. So yes, so it often the most common presentation or the earliest presentation is painful, sore, cracked nipples because the child is just sucking on the nipples, very shallow latch. And just to say that what I've seen is that it's all about the relationship of the baby's mouth and tongue to the mother's nipple. You might have one mother who has flat inverted nipples and the child has a very small tongue tie, and that tongue tie causes massive problems because of his relationship of his mouth to this mother's breast. Where you could have a mother with a very large nipple and the child has a terrible tongue tie, which goes right to the front, and there's no problems because her breasts compensate for that. And that's why often we'll see those children who have very, very bad tongue ties. They'll either present at the age of 4, 5, and 6, and they can't pronounce the R's, the L's, the S's, and the TH's. And that's because their tongue is tied down and they can't do a proper tongue thrust. Or just see them later on in life, sometimes it actually gets caught between the lower incisors, between the teeth. So the oldest person I've done a tongue tie on is a 21-year-old because he said that it was catching on his lower teeth and it was actually quite painful.
Wow.
So present at different times of life in different ways.
That's amazing. And I think such a valid point you make there, because just because, and this now makes so much sense to me, because I've had a look at a child and gone, but that must, look at the tongue tie and go, that must be causing some sort of drama. And the mom says, no, I have no feeding problem. And now can kind of go, well, maybe it's not just the tongue tie, but it's the environment in which the tongue tie is operating. So if the nipple overcomes that, it becomes fascinating.
Sure. So, but those ones that are often seen, those very, very anterior tongue ties that go to the tip of the tongue, probably should be cut just to prevent problems later on in life. But if it's one that is not causing any problems and it's not such a big tongue tie, then I would just leave it. So often my history is so important, and we can go into that now. What the mother tells me about the feeding, what the lactation consultant tells me about the feeding, guides me on whether we're going to cut it or not.
I think let's move right into that. Let's look a little bit at the history and what are the little bits and pieces of information that you're looking for there.
Okay, so I always ask them tell me about the first latch. When there's a bad tongue tie, it's often from the first latch. The child can't get under the nipple, and they tell me how it's excruciatingly painful, and the nipples are cracked or bleeding. And because it's a superficial latch, when they finish feeding, the nipples are almost lipstick shaped or squashed. Second of all, each time the child slips, so the tongue goes underneath, and with each suck, the tongue slips and slips and slips, you'll hear a clicking noise. And that's often a giveaway. You'll hear a clicking noise. That clicking noise is the slipping of the tongue off the nipple and hitting the palate. Then with each slip, they're going to gulp in air, which makes the child very, very gassy. And that gassiness causes them to be unhappy. They can often be colicky and refluxy, which is often, we'll send to you guys or we'll get them from you guys because that's one of the causes of colic and reflux. So they have a lot of air in the tummies. They unhappy babies. They have clicking. The moms have sore nipples, and those in general. If the mother tells me that in my history, I already know that this child's got a tongue tie and we've got a latching problem.
Okay. So that's really what you're looking out for in that history. You said we were going to talk a little bit about grades. Would that history kind of give you an idea of what kind of grade it is that you're
so doing? As I said, it's all about the relationship of the mom's breast to the baby's mouth. For example, when I was 12, I only had mine done. So I said, Mom, wasn't it terrible? I said to her when I qualified as an ENT and I was doing this, wasn't it painful for you to breastfeed? Myself and my sister had one as well. So just to sidetrack a little bit, their tongue ties are genetic. They often run in families, and they're more common in boys than in girls. And as I said, my sister had, I had, my first cousins had, 3 of my 4 kids have. I said, wasn't it sore to my mother? And she said, well, we were just told that that's how breastfeeding was meant to, that's how breastfeeding is. It was hard. And you just carry on like that. So I don't know if moms were treated differently back then. It was a more like a patriarchal society, and kind of like that was your job and you had to breastfeed no matter what. But they did, and they got over it. Maybe it hurt in the beginning. Another thing that I heard a great analogy from a colleague of mine, that nipples need to be, or skin needs to be conditioned. They gave the example of a martial arts fighter that they would take broomsticks and whack their shins and their elbows, or take bottles and whack their shins and their elbows, so that they would become conditioned, so that when they fought, they would be a lot harder. Now you can imagine a first-time mom who's never ever breastfed before, and now they're having a child sucking on their breast for an hour every 3 to 4 hours. You are going to get skin changes and some pain inside in the nipples. Now you've got to differentiate between what's a normal pain and what's a pain of a first-time mom. So usually the first-time moms or early breastfeeding pain will resolve within a day or 2. But if those blisters or cracks persist and it's unusually painful, then we start to worry and think about a tongue tie. So I actually forgot now how we got onto that when I sidetracked.
That's all good. We were just talking about potentially working out the different grades of the
Okay, so I can't tell a different grade from the history, because as I said, it's all I've had a grade 1 tongue tie, which we'll go into now, which is the furthest back tongue tie, which is close to the base of the tongue. A grade 2, which is a tongue tie which is about 50%, grade 3 about 75% of the tongue, and grade 4 goes all the way to the front of the tongue. When the baby pushes, or the child pushes the tongue out their mouth, it becomes heart-shaped, and they can't put it over the inferior gums or teeth. So very difficult to tell by history, because as I said, the mom's breast can compensate for that.
Okay, and when we talk about that heart, you're talking about as they come out, the heart is visible.
As they come out, it's almost, if the tongue's meant to be point-shaped, as they come out, it kind of folds in like that.
Okay, so that's where we're looking for.
Flower shape, yeah.
That's all good. Right, so, but tongues are not the only things that can get tied around oral tissue, because they talk about TOTs, right?
Sure.
Tethered oral tissue. So
yes.
We're talking about other things as well that can get tied.
Lips and buccal ties. So any time that there's fusion between embryonic structure, so we know that the tongue and everything in the face is formed from 2 halves. And the most common way I explain to people is that we've all seen children who have cleft lips or cleft palates, and that's when the 2 halves of the face fuse in the middle. So the 2 halves, both sides, the right and left lip, are going to fuse in the middle. The right and left tongue are going to fuse in the middle. So anytime when you get parts of fusion, or places where 2 structures are joining, you're going to get a membrane or something joining them. Now, lip ties are much more controversial. There's not a lot of evidence to showing that lip ties play a part in feeding and cutting feeding, and cutting them improves feeding. There's very little evidence to show that. Okay. So a lip tie, most commonly in the upper lip, goes from in between where your 2 incisors would be onto the upper lip, and usually most of them regress when the teeth grow. Most parents actually worry about, will my child have a gap between their teeth? But when they get their adult teeth, it usually kind of squashes or regresses upwards. We don't worry about lip ties too much from a feeding point of view. So what usually, when parents come into me and they say they've, obviously the internet's a dangerous place to read about different things and can cause hysteria. And they'll say the lip tie is causing everything. So often it will be either a missed tongue tie, which is much more common than a lip tie to cause problems. So as I say to them, your first line of defense of suction is the tongue that needs to get under the nipple and form a suction. If the child can't form a suction with their tongue, then they'll try with their gums and they'll bite. And if that all fails, then kind of it's the lips, because that's third in line. If you see the lip flanging in, so the lip usually goes out onto the areola. If the lip is curved and flanging in,
Mm-hmm.
we can have problems with forming a tight seal and suction. So lip ties definitely need to be noticed and acknowledged and looked at most of the time. You can watch and wait. Only if the lip is flanged in and the child's still not coping with feeding, once we've assessed for a tongue tie and cut the tongue tie, then we'll go for the lip. The lip is a much more difficult and lengthy procedure. It bleeds a lot more than the tongue. It's more traumatic for the baby, the mother, and myself, or the person doing it. So the tongue ties is the lip ties are almost a last resort. Buccal ties are often where the inside of the cheek, the mucosa on the inside of the cheek, the non-keratinized squamous mucosa joins to the gums, the upper and lower gums. They can be buccal ties, also very rare that they cause feeding problems. But if you assess the tongue, you assess the lip, and the child still isn't feeding well, then kind of you'll go and cut those membranes between the cheeks and the lips. And this is also obviously once they've seen a lactation consultant and established that the mom her positioning is right and her milk flow is good and the child's in the right position and he's getting a deep enough latch. Mm. So often when patients will come to me and it's a very bad anterior tongue tie, you can cut and things go back. Instantly, the mom has a change. The feeding's much deeper, much less painful. But often if it's a posterior tongue tie, or the child's had the tongue tie for longer, and just to go back onto the history, if they bring you a child who's 1 or 2 months that's not putting on weight, so the feeding's okay, the mom's nipple is compensating, the breast is compensating, but the child's not putting on weight, and or very, very colicky and refluxy, often there'll be a very subtle tongue tie. And if we address that tongue tie, they've seen the lactation consultant post tongue tie, done some exercises to try and get the tongue stretched and get that latch nice and tight, then we'll consider looking at the other oral restrictions like the buccal ties or the lip ties.
Okay. Doc, I do have one question. This is I'm just thinking of like questions that I've been asked in practice, because obviously with the lip tie, there's a worry of speech later. Is there any worry that, I mean, with the tongue tie, is there any worry with the lip tie later that it would need to be cut?
So we worry more about that it's going to cause gaps between teeth. Okay. Because it's on the outside of the mouth, of the teeth, the lip tie plays a very, very small role in speech. So we're mainly concerned about a tongue tie when it comes to speech, but not the lip. Okay. More from a dental point of view, we worry about.
Okay, thanks for that, because I actually had that question through this week.
It's very common. Parents often do ask that, and they often ask that, what problems is the lip tie going to cause?
That's wonderful. I can take that back to them, because I said I'm going to be speaking to the expert this week. Perfect. So I can get the proper information for them. All right. So what does a basic examination look like?
Okay, so we take obviously a history from the mother. History is the most important, as it will guide me to what the problem is. Usually, as I said, we can tell if it's a tongue tie just from the history. The mom's saying painful, cracked nipples, usually worse on one side, clicking, very gassy. If it's a few weeks down the line, the child not putting on weight, crying a lot, some bringing up of food quite often, and that will guide me towards a tongue tie. They'll often tell you maybe if it's a lip tie that the lip is flanged or curling in, and that their nipples are lipstick shaped after the feed, and not much of the breast is going into the mouth. We'll then take the baby to the bed. I sit at the head of the baby. The mom sits on the other side of the bed holding hands, and I use a headlamp. And we look into the baby's nose to make sure that there's no obstruction in the baby's nose. As we know that children are obligate nasal breathers. And if they can't breathe through their nose, they're not going to be able to feed well. And they'll cry, and crying is the only time that they can breathe during that feed. We'll then go into the mouth, flip up the upper lip, have a look at the lip. If you can fit your finger as a general rule, between the upper gums and the lip, then there's usually a good stretch. You can often see that whether the lip is mobile or not and how bad the lip tie is just from doing that, pulling the lip tie up. If it's really, really pulled down, it is going to possibly affect the suction and the seal. So we might consider cutting that. I usually watch and wait and see, as I said earlier, if the lip tie needs to be cut. I then put my fingers underneath the tongue of the child. And if it's a very big grade 3 or grade 4 tongue tie, you'll see that membrane straight away straight in the middle. You might see some white on the tongue from the child not clearing the tongue and the palate properly. So it can be confused with thrush sometimes, but there might still be a big white patch of milk on the tongue because the tongue won't reach the palate and clear itself properly. And we do see that in older children with tongue ties as well. When they're starting solids, they often don't clear the palate properly because the tongue is anchored down. Then run my finger along the base of the tongue, between the floor of the mouth and the base of the tongue, and you'll feel what's like a speed bump in the midline. That's the posterior tongue tie. Then put my index fingers on either side of the suspected tongue tie and try to stretch the tongue towards the palate to see if we can see the tongue tie. It's often quite fibrotic and thick. It often just looks like a mucous membrane, or sometimes it's a deep, high-riding muscle, as we discussed earlier. I'll put my index finger in the child's mouth, feel the palate. Sometimes a harsh palate can be a problem. Can be normal, or it can just be in different syndromes. Then what we do is I get the child to suck on my finger and tell how good their suck is, how strong their suck is. I'll then have a look with my fingers at the buccal mucosa and see if there are any buccal ties, and then run them along the bottom gums to have a look if there's a tie on the bottom lip, which is very, very rare as well. To that point, when I'll tell the parents, listen, the child has or hasn't got, and then we'll discuss the pros and cons and the process of actually cutting the tongue tie. Often lactation consultants will send the moms a picture or a video of me cutting a tongue tie, because it's often thought to be a massive procedure and a very scary procedure, and the unknown's obviously always very scary, especially for a parent of a newborn or a first-time parent. So explain to them that it's a very, very small procedure. So a lot of doctors have a different philosophy about tongue ties, because not so many doctors or ENTs or pediatric surgeons deal with them so often. They'll often take them to theatre to do them because they're more comfortable in theatre, maybe because of the bleeding, the baby moving, having the mother there. But I think I've just become used to it, or maybe more comfortable with it, because I've seen a lot of them now. It's a big part of my practice, that I don't take the children to theatre, and often I will get referred from other lactation consultants or doctors, because some doctors only take them to theatre, which is quite a schlep, especially with a newborn, to starve them and take them to theatre. It's often quite a scary process. So what I do is I take a local anesthetic spray, and because the tongue is mucous membrane, the anesthetic is absorbed straight into the tongue, working within 30 to 45 seconds. Then I usually take my left hand, put both fingers underneath the tongue, stretch the tongue up, and in my right hand have a scissors, have the parents hold the hand and slip the membrane all the way down until I can see the muscle fibers underneath the tongue. I then take a gauze swab, and the gauze swab will be soaked in local anesthetic with adrenaline. We put it underneath the tongue, and that, number one, the local anesthetic gets absorbed into that wound, and the adrenaline in the anesthetic also stops the bleeding. And there's a little bit of blood in the saliva for a few seconds, but it's really, really a simple, small procedure, and it's often the fear of the unknown that the parents will really be worried or scared about. Blood in the saliva for 10-15 minutes afterwards, and that's usually the point where the local anesthetic wears off, and the children will be able to feed again straight after. So it's a quick in-office procedure. Parents are usually at my rooms for 15 minutes to half an hour. And as I say, if it is the correct diagnosis of a tongue tie, then we will, it's really life-changing for the baby and for the mother. If I'm in doubt whether it is a tongue tie or not, often I'll make sure that they've seen a lactation consultant, tried everything with latch and positioning, etc. And if they're still not coming right, then we will cut the tongue tie. It's often a case of the risk and benefit. The benefit is huge and the risk is very, very small. And I'll explain that to them. It's a small little snip under local anesthetic. If it works, you've gained a hell of a lot. If it hasn't worked, then you haven't lost much. It's a little bit of blood. And,
absolutely. And I tell you, being able to just say to parents, because the moment they hear tongue tie cut, something goes off in their head where they're like, this is going to be a horrible thing. And I think, like you say, a lot of them are thinking it's going to be an in-theater thing. I'm going to have to anesthetize my child like general anesthetic. And it's something that they really go, no, hang on. Let's rather. And once you can go through, look, it doesn't have to be that, and explain the procedure to them, it becomes a lot easier to swallow.
Yeah, sure. So often fear of the unknown is the worst thing. And that's why I like showing them a video before I even do it, or getting the lactation consultants to send them the video. I've also got the video on my Facebook page or my website. So, because people will have a look. Often, as I say, the internet's a dangerous place. They might watch other people doing tongue ties and fear of God put into them. They might see one being done, a lot of blood, screaming, holding the baby down, everything which you don't want to experience as a parent.
Yeah. Listen, you're talking to a chiropractor. You should see the chiropractic videos on YouTube. Don't worry.
Really? Yeah. So we all,
there's some ninjas out there, man. Proper ninjas.
Exactly. A lot of, exactly. Ninjas is a good word. So we want to try and educate the parents on what the proper management is, that it's a safe, successful, very, very minor procedure that we can do safely in the rooms.
Yeah, fantastic. Doc, I would like to speak to you about us as chiropractors, physios, lactation consultants. I know we got a couple of GPs on here. I know we got a couple of peds on here.
Yes.
What are our red flags to be able to go, right, I need you to move over to Dr. Gersun? What are we looking for to be able to make that call?
So the most important thing for me is the history. We want to find out from the parents, is the feeding very painful? And moms do experience a little bit of pain, especially in the beginning. But if that pain is worsening, if there's bleeding or cracking on the nipples, that isn't getting better. Pain is excruciating. If there's a lot of clicking, child very, very gassy and uncomfortable, squashed or flattened nipples, or the child is just screaming because they're not getting enough milk, then I think it's a good time to have it assessed, either by a lactation consultant. They're usually my first port of call. And if the positioning, and there's enough milk and there's a strong enough latch, then or a good latch position wise, then I think you kind of send them. If you see in the mouth a tongue tie that goes right to the end of the tongue, that it looks like a heart or flower, the child can't get the tongue out over the bottom teeth or bottom gums, that there's a white patch over the tongue, those are all reasons to refer. As I say, not all tongue ties are symptomatic. If the moms are happy and feeding well, I don't think there's many reasons to cut. As long as they're putting on weight and they're happy and the mom's happy and she's not in pain.
Yeah, fantastic. I think that's one of the things I've really enjoyed about being able to refer to your office is one of the things that moms will say is, oh, but I don't want to, well, it mustn't just be a cut, and to go, look, it's an assessment more than anything.
Sure.
It's a further assessment with an expert in the field. This is not about sending you to go get it cut. This is about sending you to see, this is the next level, to see, is it actually necessary or can we carry on without that?
Sure. I think there's a lot of cowboys out there and scissor happy people out there that just cut. I don't cut unnecessarily. And I think that's something that the parents appreciate. And if you cut that unnecessarily, I think you often get a reputation for being, a cowboy or scissor happy. And as you say, it is an assessment, and to give them the options and to say, we're going to try this and this and this. And if that doesn't work, then we'll cut the tongue tie. Or if it's something that really, really will help them there and then, explain that to them, explain them all the risks and the benefits, and do it right there.
I would like just to say, and you talk about it a lot, which I really, really appreciate. When I found lactation consultants, my practice changed almost completely. Yes. They have become advocates for moms and new parents. And I think, as you said right in the beginning, where we talked about where your mom kind of said, well, it's supposed to be painful. There weren't many people in that position advocating for moms, and to be able to go, it can be tough, but it shouldn't be painful. And to be able to give them, that ability to be able to go, we can move through this, or where do we go? And I know even with my setup, I mean, my kids are 11 and 13 now, but we didn't have that when we were in place there, and I mean, I know that my wife would have loved to breastfeed for longer, and I'm pretty sure we could have got that going had we had the kind of advocacy that moms have now. So I would just like to sort of add to what you're saying there, just to shout out to lactation consultants. And as as someone, if you don't use them in your practice, oh my goodness, start using them, because they are brilliant.
Yeah, so from they as well changed my practice. My tongue tie practice has grown tremendously. Number one, because I tell them that I will see if there's a tongue tie, because it's such instant change. I'll tell them always that I'll see the baby within 48 hours, and that they can phone my cell phone if they've got a tongue tie. We try to treat it as urgently as possible. So they made my practice grow tremendously, sent me so many patients, and also helped patients that I couldn't have helped. And we've often brought them in if we're not sure what the problem is, and they'll come to my practice and we'll work with them together, and we'll check the latch before and after, and to get the best from the baby. And I don't think they were around 10, 15 years ago. I know overseas they've had lactation consultants for the past 15, 20 years or so. And lactation consultants aren't just nurses, they're physios or OTs, dietitians, speech therapists who have done the course in lactation consulting, which I think was only offered here in the past 5 years. But they're a massive part of my practice before and afterwards. So they refer to me and I refer to them, but they have changed my practice completely. And also, I can't emphasize enough, if there are children having, or moms having feeding problems, lactation problems, to send to a lactation consultant for an assessment.
Yeah, no, they really are fantastic. And Doc, yourself, thank you so much for your time. I think that has been a wonderful explanation, and a real good, like almost demystifying as well, around tongue tie, because I think for a lot of people, especially us in the allied fields, where we're kind of going, well, we want to be able to deal with this, but sometimes we just miss those basics of what is it, what should we be looking for, when do we refer, and when is it a red flag? And I think we've kind of furnished a lot of people with that information. So thank you very, very much for that.
Good, pleasure. I'm always happy to speak and educate and give advice. And whenever you or yourself or any of your colleagues want to call to discuss a patient or a case, I'm always happy to do so.
Oh, Doc, thank you very much. Dr. Dean Gersun ENT, thank you very much for being with us here on the Pediatric.
Thank you for hosting me.